Thank you, Roxana. First of all, thank you for the invitation to participate. It's, believe it or not, it's my first time in New York. I've been to the US maybe 100 times, but it's the first time in New York. Yes. These are my disclosures. Probably the most important one that is not listed is that I'm not an interventional cardiologist. Just keep that in mind. So for many, many years, we have been looking into ways to find the vulnerable plaque. Then we went to the vulnerable artery and then to the vulnerable patient. But in reality, what we have learned over the years is that it's not these very big plaques that tend to rupture, especially if they are calcified. It's the middle size or small non-obstructive plaques that very often rupture, giving heart attacks. And what triggers this plaque rupture is inflammation. We have heard a lot about inflammation earlier, and I'm sure we'll hear more in the subsequent talks. Now, in a recent study that we have published in the UK, from a UK population, we include 40,000 patients having coronary CT angiography because of chest pain. Only 18% of them had obstructive coronary artery disease, but 2/3 of the heart attacks happen among those who did not have obstructive CED, among those that were discharged home as needing no further intervention. And we have seen very recently the PREVENT trial showing that if you identify the non-obstructive high-risk plaques with intravascular imaging and you stent them, you improve outcomes. At least you push events 2 years later. And now, with all the AI revolution that we have earlier, it's the industry standard to use AI and perform automated plaque quantification, identify the high-risk plaque, quantify it, and then identify the patients who may need some additional interventions. However, we focus a lot on non-calcified plaque, but non-calcified plaque is not necessarily inflamed, because there is non-calcified plaque that is not inflamed and is not high risk and is not going to give heart attacks. How can we do better? In my lab in Oxford, we have used translational methods, ex vivo models of human vessels, etc., to study how the fat surrounding the vessels interact with the vessel itself. And we have seen that when you have an inflamed artery, before you have any plaque, you have changes in the fat surrounding these arteries. If I get a biopsy of the fat around an artery, I can tell you whether the artery is inflamed without even touching the artery. But of course, we cannot open the chest of the patient to get these biopsies. And of course, this happens before any plaque is developed. With coronary CT angiography, we get these nice black and white images that do not show what's going on around the vessel, because that area is black. We develop a method that uses an AI modeling of the perivascular space and essentially brings this information to the surface and turns our black and white pictures into colorful images. And you can essentially identify the inflamed artery by looking into this distribution of the red color in the perivascular space. If you have red, it means that the artery is inflamed. If you have blue, like what you see here, it means that the artery is severely inflamed and then there is an imminent cardiac event, even if there is no visible plaque. And I'll come back to this in a second. Now, we are lucky in Oxford to have this hybrid cath lab where is combined with a photon counting CT scanner, and the table of the cath lab slides into the photon counting scanner, allowing us to visualize rupture plaques even during primary PCI. So you get these acute cases and you don't add any time to visualize, to perform a photon counting CT angiogram on the acute phase. And this has taught us a lot. You can see how nicely this lesion here lights up as red, identifying that this is indeed an inflamed plaque. And we have now, by using this method, sensitivity and specificity above 90% to find these culprit lesions. When we developed this method, the fat attenuation index, we had to turn it into a clinical application that will be robust, applicable in all 3 coronary arteries, and reproducible across different scanners, different settings, different countries. And that's why we essentially developed the fat attenuation index score, which is an AI-enhanced metric of these changes that happen in the perivascular space. that has received the label in Europe and in the UK as the only imaging biomarker of coronary inflammation. And you can see more in this recent clinical consensus statement by the European Society of Cardiology on this topic. What does it capture? This is from post-mortem studies. You can see that if you measure inflammation by using this AI technique, you can essentially capture very nicely the infiltration with CD68 positive cells, and it's also very specific for T-cell immunity in the vascular wall. Now, if you can measure inflammation, you can predict risk, and this is exactly how you predict risk by using this approach. If you see here, in this CRISPR-T study, 2,000 patients from Cleveland Clinic with Millie Desai, 2,000 clinics from Erlangen, led by Stefan Eichenbach. And you can see that in a model where you have age, sex, risk factors, calcium score, and non-calcified plaque, high-risk plaque features, you gain an area under the curve that goes up to 7.5 units on top of that if you add inflammation. So this is something that we have been missing for many, many years. Of course, when you run this AI training, these models, you need big numbers. And this is what came to change completely the landscape. The orphan study aims for 250,000 patients with coronary CT angiograms linked with lifelong outcomes data. We are now at 210,000 patients, and we are essentially expecting to meet the target of 250,000 by end of this year. Now, a big number of these patients, aiming for 200,000 of them, are from the UK. And these are the first pilot data published a few months ago from this orphan study. You can see that if you measure inflammation by using PHI-score and your arteries are above the 75th centile of the distribution, you have 10 times higher risk to die from a cardiac event if you have no obstructive disease, and 5 times if you have obstructive CAD. Now, we have plaque. We have all these tools that measure flow, hemodynamic significance of lesions. Do we need to know about inflammation? Yes, because if you look into the 40% of the patients who have no plaque, so they came back as calcium score 0, no plaque, this is what happens with their risk. If you look into their 10 years risk, in those with calcium score 0 and no visible plaque, you see that if you have inflamed arteries, you have 10 times higher risk to die from a cardiac event over the next decade. If you have CARTRAT 0 or 1, so you may have some irregularity of the lumen, but again, no calcium, you get a 9.5 times higher risk for a fatal cardiac event. If you have a small plaque, again, similar observation. And again, when you have large plaques, if they are inflamed, then these are the plaques that are going to give you the cardiac events. And all this on top of calcium score and quantitative plaque assessment. How do we treat inflammation? That's very simple. At the moment, the only tool that we have that is very, very robust is statins. Within a year's time, after you start statin treatment, you reduce inflammation in your coronary arteries by at least 30 to 40%. And of course, biologics, like for example, this randomized controlled trial with ortiquumab, with this antioxidase LDL monoclonal antibody, leads to a striking reduction of inflammation in the coronary arteries. But of course, we are waiting to see the results of large randomized clinical trials with the novel biologics to see how we can treat these patients. Now, I talked to you about plaque, quantitative plaque assessment. We have the risk factors. I'm telling you about inflammation. We have our stethoscope. Are you not confused? So how are you going to use this information, make decisions for the patients? So AI is here to help us give some order to all this information and allow us to translate this into what we know how to treat best, which is absolute risk of the patient for a cardiac event. And this is exactly what we have done. We have trained a model that gets coronary CT angiograms, performed as part of clinical care, extracts information about plaque automatically, about inflammation. It takes into account the risk factors of the patient, and then it gives you a prediction of risk. This model was trained in the CRISPR-T study. It was then validated as a locked medical device in the UK population of the orphan study, giving you a C index for cardiac mortality 0.84, which is, it sounds unrealistic, but this is what you can achieve with this AI. Now, in clinical practice, we treat levels of risk in a binary way. All the guidelines, they tell us that if, I'm mentioning here the NICE guidelines, but the AHA, AC guidelines are more or less the same. If you have low or medium risk, is lifestyle and diet. If you have high risk, start statins, increase dose, or if you are at very high risk, start additional treatments. And colchicine is also one of those, despite the results of the clear synergy study that was published recently. Now, what you see here are events predicted by the AI model, are not true events. When we plotted this graph, we then opened the labels and recorded the true events. And these are the true events. The solid lines are the true events. So this is what you can achieve with this kind of technologies. In the UK, this has been commissioned by NHS England, is being used, and we record changes in management. And as you can see here, 45% of our patients change management when this information is taken into account. 24% start statin treatment, 13% increase the dose, 8% go for the additional treatments, including colchicine. Now, in conclusion, chronic inflammation drives atherosclerosis, atherogenesis, and plaque rupture particularly. Measuring chronic inflammation is now possible with CT, with the fat attenuation index score, and you go beyond calcium score and visible plaque. And of course, you will need AI to put all of this information into perspective, turn them into risk, and then guide management for our patients. I will leave it here, and we'll have discussion later. Thank you.
Thank you.